Okay. Okay, hang on, my computer's not wanting to pull the PowerPoint up here. Hang on one second. My computer apparently wants to not do the PowerPoint either. Okay, can you guys see that okay? Yeah,
Yes.
okay, thank you. Okay, so this week we'll start with cerebral dysfunction. Okay. Oh, is it paused? All right, can you see now? Yeah, okay. All right, I'm gonna scooch this down here. All right, increased intracranial pressure. So this is obviously a form of cerebral dysfunction. So the brain is well protected by the skull, of course. In early infancy, the fontanelles open. So if there's increased intracranial pressure in an infant, you will notice bulging, which is what this picture is showing. So that fluid is trying to essentially escape or kind of reduce the pressure. So that's when you see that bulge in an infant. Okay. In an adult or an older child, you might see like level of consciousness changes, blood pressure changes, things like that. And that's pressure that accumulates within the cranium is what you're noticing with increased intracranial pressure. Okay. You'll also notice like pupillary changes, but the biggest one you'll notice as it becomes more progressive is the level of consciousness changes. Okay. So in an infant, like I said, you'll see that fontanelle bulging. You'll also see separation of the cranial sutures, which that's what fuses after a baby is no longer an infant. You'll see the sun setting sign, so that's changes in the pupils and the extra ocular muscles also not responding as well as they typically do. In an infant, they'll be irritable. They're not going to eat well. They'll be hard to soothe, like a kiddo who's typically easy to soothe. They're going to be really fussy, and nothing you can do can calm them down. And then you'll see distended scalp veins. So you'll see vein distension. So if you're starting to notice these symptoms in a kiddo, specifically in an infant, then it's a major concern. If they're at home, they need to be seen in the ER. If they're in the clinic, they need to be sent to the ER. And then, of course, if you're taking care of them in the hospital, you need to be calling the provider. Increased intracranial pressure signs in children, they're going to have more of the adult-like signs that you think of: headache, forceful vomiting. This is like projectile, very aggressive vomiting, seizures, not able to move their body as well or as coordinately, and then changes in level of consciousness. For example, they're not able to follow simple commands, or they're not responding to you talking to them. late signs, you're going to start to notice the cardiac changes. So bradycardia, you're going to start to notice those pupillary changes. So one pupil, just like in this picture, will be more dilated than the other. Okay. Posturing, you might notice that late. And then, of course, if it continues to coma. Levels of consciousness. So this is in descending order. So full consciousness, confusion is the next kind of decreased step of consciousness. So you're going to have impaired decision making. You'll then see disorientation to time and place, and then lethargy. So their speech is going to be sluggish. They're not going to be responding to you as appropriately as they were when they were fully conscious. You'll also see sluggish pupil reactions a lot of times, hard to for them to wake up. Okay. Obtundation, so this is when they arouse to stimulation. So that is normal finding, okay. Stupor is when they only respond to vigorous or repeated stimulation. A coma is no motor response, okay. And then persistent vegetative state, this is where there's permanent loss of cerebral cortex function. So the longer someone is in a coma, then they'll eventually progress to the persistent vegetative state. Okay, here's your coma scale. Just like with adults, you're looking at their pupil response, their verbal motor response, eye opening, and then motor response, okay? So scores of 8 or below are considered common. A score of 3 is the worst score that you can get. Neurological exam. So obviously your vital signs are going to be a part of this, looking at their skin, especially if they've had like a seizure or something, you might notice skin changes on your exam findings. A part of your neurological exam is checking their eyes, so doing pupillary response, doing their ocular motor movements, checking those muscles, doing your nerve tests. Okay, so looking at your functioning, and then how their posture, okay, and do they have their appropriate reflexes that they should have, or are some of those lacking, okay? So these are some different pupillary findings that you might notice on your exam, okay? Pinpoint pupils, you know, this might happen if someone's intoxicated, like with opiates or something, okay? So if you're noticing abnormal pupil sizes or, you know, a variation in the sizes of their pupils, then that's going to be concerning for a neurological compromise. Okay, here's their posturing that we talked about. So decerebrate posturing is the more rigid. So these are two forms of decerebrate posturing, and decorticate posturing. You can see that there. That just is telling you which portion of the brain is affected with the neurological dysfunction. So special diagnostic procedures for increased ICP, you can have kids get EEGs just like adults. They may need lumbar punctures. They may need lab tests. So looking at their electrolytes and things to make sure that, you know, their sodium isn't sky high, that they're seizing from that, or another abnormal electrolyte, or, you know, their CBC isn't off for concerns of like a brain tumor or something. So labs are typically a part of the diagnosis for increased ICP. Making sure that you can evoke responses, both auditory and visual responses. So, you know, speaking with that child, do they respond, you know, by opening their eyes if they had their eyes closed, waking up, or, you know, doing tracking with visual stimuli. And if there's any abnormalities of that, you would be concerned for neurological dysfunction, potentially increased ICP. Imaging wise, you want to rule out school fractures, dislocations of your spinal cord or spine, and then any degenerative changes or, preemptive closure of those suture lines. Okay. And potentially an MRI or a CT scan to be looking for some of those tumors or some, seizure activity that you may be able to see on MRI. Okay, caring for an unconscious child. Similar to adults, your biggest concern is going to be like making sure you're repositioning these kiddos so they're not getting sores, and then also providing them, oral care because they're going to be ventilated. Okay. So keeping their airway, reducing their cranial pressure, and then any treatment of shock. So they might be getting fluids, blood transfusions, all sorts of things can be going on with these kiddos. And then you'll have to be really in tune with your exam findings on these kids because things can change pretty quick. So if their vitals start changing, it'd be important that you, as the nurse, are keeping track of all the changes that are happening with these kiddos. We kind of have already talked about. So you may be doing your neurological exams more frequently, usually with a kid with neurological changes, especially increased intracranial pressure. They're going to be in the pediatric ICU or the NICU, and you'll be likely assessing neurological assessments every 15 minutes to potentially every 2 hours, maybe even every 4 hours, depending on if they're pretty stable. These assessments will include your vital signs plus your pupillary reaction, your level of consciousness of the kiddo, and then, like reflex testing and things like that as well. And then, of course, if there's any variation from previous assessments, you should be letting the provider know right away. Respiratory management. So airway is a major concern along with the increased intracranial pressure. Okay. If these kids have hypoxia that's lasting longer than 4 minutes, then a lot of times they have irreversible brain damage. Okay. Carbon dioxide retention then causes vasodilation, which then further increases the cerebral blood flow. Okay. So worsening the intracranial pressure. As intracranial pressure continues and as the child's comatose for longer, you'll see those gag and cough reflexes diminish essentially. And then as those gag and cough reflexes diminish, your risk for aspiration increases drastically as well. There's different ways to monitor intracranial pressure. Usually it is a line like this, kind of like an arterial line that happens. This obviously is happening with a kiddo who is in a coma. They have to have a Glasgow scale of less than 8, okay? You'll also see these happen after kids have had TBIs or traumatic brain injuries and have abnormal CT scans. So a lot of times when you start your ICP monitoring, okay? You don't do this on a kiddo who is stable, okay? So intraventricular, that's, like I said, the type of monitoring that happens like through like that's similar to an arterial line that's placed. The Richmond screw, that's what you're seeing in this picture. It is a subarachnoid bolt, so they put that bolt in and then thread through a sensor that then can read that intracranial pressure minute to minute, second by second. They'll place an epidural sensor at times that's going to go into the spinal, the epidural space, which you can see that here. And then, oh, excuse me, I said subdural bolt is here. And here's your subarachnoid bolt. And then your subdural catheter, that's what's was in this picture here. Okay, that's just going to go right into the subdural space and read that pressure. And then they can also place through the anterior fontanelle. Patient positioning. So if we have increased intracranial pressure, elevate the bed at least 30 degrees and keep it at that at a minimum. You'll need probably a special pressure mattress, so that way these kids are not getting pressure sores from being essentially in a coma. Avoiding neck vein compression, because that's going to also increase intracranial pressure. And any time that these kids start to get agitated, that's going to further their increased intracranial pressure. So you're going to want to try to keep stimuli to a minimum in these kids' rooms, okay? So not a lot of environmental noise, not a lot of visitors during these times. And then suctioning, also you can see an increased intracranial pressure with suctioning, so trying to do that you know, as often as you need to maintain their airway, but also not being overly aggressive with your suctioning. Nutrition and hydration for kiddo with increased intracranial pressure. A lot of times it's going to be IV fluids, or they're going to have like TPN going through a PICC line. So parenteral nutrition. They may, if they continue to have increased intracranial pressure, that's when you'll see them place like an NG or G tube and do gastric feedings through their NG tube or through a G tube. Okay. And the biggest thing as you're feeding these kids is keeping an eye on overhydrating them. So them getting too much food that's causing their ICP to worsen, or monitoring, you know, that they're not vomiting and being at risk for aspiration. Okay, here's a question. You're caring for an unconscious child. What is your appropriate nursing intervention? A, change the child's position infrequently to minimize the chance of increased ICP. Avoid using narcotics or sedatives to provide comfort and pain relief. C, monitor fluid intake and output carefully to avoid fluid overload and cerebral edema. D, give tepid sponge baths to reduce fever because antipyretics are contraindicated. You guys can just unmute.
C.
C.
Yes. Yep. Good. Okay. Chapter 47, endocrine dysfunction. Okay, so disorders of pituitary function. So your pituitary is a gland that's below the hypothalamus in the brain. So an issue with the pituitary gland can cause several different endocrinologic issues, okay? It might have one hormone that it's affecting that's throwing the system off, or it might involve multiple hormones that are dysfunctional, okay? The presentation of the child's symptoms is based on the pituitary issue and whatever hormone that's involved in the pituitary issue. Okay, sometimes there's an overproduction or sometimes there's a deficiency in that hormone. Okay, a lot of times it's kind of just an unknown cause or a defect that happens, you know, during development, and not necessarily, you know, a known cause of the change in pituitary function. So hypopituitarism, this is growth hormone deficiency, okay? So these kids are not going to grow as tall as other kids their exact age, okay, because of the growth hormone or GH deficiency. A lot of times based on the severity of the dysfunction, you'll see a gonadotropin deficiency as well. So our sex hormones won't develop, and our secondary sex characteristics will not develop because we have gonadotropin involvement, as well as the growth hormone deficiency. TSH or thyroid stimulating hormone, that is what stimulates the thyroid to make thyroid hormone. So you'll a lot of times see thyroid deficiency as well in these kids, and corticotropin deficiency. So what you're going to see is these kids will be on their growth chart with their height, and then all of a sudden they're dropping off of that growth chart. Okay, so they're going from maybe 50th percentile on their height growth chart all the way down to, 5th, 6th percentile or lower. And then as they progress towards puberty, you're not seeing those secondary sex characteristics changing. So if you would notice a kiddo like that, it'd be important to refer these kids to endocrinology and let your provider know that parents are noticing this, or you noticed it on your growth chart. Okay. So yes, usually within the first year, they have normal growth, and then their growth starts to slow down. They might be more overweight because their height has been stunted. Okay. A tumor can cause hypopituitarism. Okay. And then, like I said, delayed sexual development is kind of another thing that you'll notice. So how you manage growth hormone deficiency, you give them growth hormone replacement, okay? Typically they reach, like when they start reaching their max growth rate, so they're not growing more than an inch a year, then that is when the growth hormone is stopped, okay? Usually growth hormone's pretty successful. It helps kids reach their peak height, in about 80% of cases, as long as it started fairly early. Okay, obviously, if there's any underlying disease process, so there's a tumor in place or something like that that's causing the growth hormone deficiency, that should also be resolved. Okay. Pituitary hyperfunction. Okay, so this is excess growth hormone. Okay, this usually happens before the epithelial shafts close. So before those growth plates close. So you're going to see an increased growth of the long bones. Okay. So these kids are going to have longer bones because their growth plates are, or their bones are getting excessive growth hormone prior to those growth plates closing. So these are going to be your tall kids. So sometimes these kids, if it's not identified early, they can reach up to 8 feet. Okay. And also you're going to notice increased muscle growth as well as height. Okay. And the weight is not going to drop off or increase. So these kids are less likely to be obese. Okay. They're going to gain weight fairly appropriately as they gain height as well. For excess growth hormone, it's all, so that after the epithelial closure, it's called acromegaly. So these kids will have some abnormal facial features because of the overgrowth prior to the growth plate closure. So you'll see the parasinus, the mastoid sinuses, those will be kind of more prominent in these kids. There may also be loss of teeth because of the overactive growth. So you can kind of see, the more prominent forehead, the jawbone, the nasal passages are kind of more affected as well. So you can see here, there's a tumor on the pituitary gland here, and that's what's causing the hyperfunction. So usually these kids are going to have a history of excessive growth during childhood, especially prior to those epithelial plates closing. Okay, so usually 14, 16 is when that happens. They will need excessive endocrine studies to make sure that there's not something else going on. And like I said, usually for pituitary hyperfunction, there's a tumor when you have a CT done or an MRI. Okay. And then if you obtain their growth hormone level, they're going to be increased. Surgical removal of the tumor, maybe radiation, may also need to be completed depending on what type of tumor it is. And then they may also have their thyroid involved. So the thyroid may need to be removed, and then they'll need thyroid hormone replacement. They may also get cortisone or steroids may be needed after the surgery, depending on the amount of the pituitary gland that they have to remove. And then they may also need some sex hormones as well. So gonadotropin may also need to be given. This is all dependent on the amount of the pituitary gland that they have to remove. If they have to remove the whole thing, then a lot of times they will need thyroid replacement, cortisone replacement, and gonadotropin replacement. Okay. So excessive growth rates, identify them early, and then the treatment should be better. Okay. Look for signs of tumors. So any neurological changes, like I said, rapid growth, that would be a concern for a tumor, because a lot of times that is what's causing the pituitary hyperfunction. Supporting these kids and families through the process, especially if they're diagnosed with a tumor that's causing these symptoms, and then address their body image concerns, because a lot of times these kids, as they progress to teenagers, they are a lot taller and have kind of abnormal facial structure. So a lot of times these kids have struggles with body image. Okay, precocious puberty. This is sexual developmental characteristics before the age of 9 in boys and before the age of 8 in girls. Okay. If this is happening before age 7 in Caucasian females or age 6 in African American females, then you need to look for a potential pathological cause. Okay. You can see issues with the adrenal glands, with the hypothalamic pituitary hormone, with the actual sex characteristics. So you can see all sorts of dysfunction that's causing precocious puberty. So looking into this from an endocrine standpoint would be important if you have a kiddo that's having like breast bud development or facial hair on a male child before the age of 9 for pubic hair, things like that. Okay. Management. So usually they're treated with Lupron, which you hear that used like as a fertility drug, but it's used in these kids to stop the prepubertal hormones and to have them produce that at a slower rate, at a more normal rate. Okay. And then as soon as it's discontinued, the Lupron, then they should progress through the normal pubertal changes. Okay. So as soon as you stop it, you need to let parents know that these pubertal changes will start right away. Okay. Supporting these kids, obviously they're going to appear much different than their peers, so that can be a struggle for some of these kids. Okay. So working with the parents on, getting them in appropriate activities and dressing them appropriately so the child feels comfortable, but also more that they're at dressing their chronological age instead of how they appear. Okay. If there's a known cause, then you treat that known cause, but a lot of times the cause is unknown. It just kind of happens in some kids. Okay. Diabetes insipidus. Okay, so this is not diabetes mellitus. Okay. You are going to see polyuria and polydipsia, which is similar to diabetes mellitus presentation. However, this is very, very excessive. So these kids are drinking nonstop and they're urinating nonstop. Okay. Infants, you'll notice that they're irritable when feeding on their usual milk or formula. However, if parents feed them water, then they seem more content. Okay. And then dehydration often occurs because they're being fed, more often water than their actual formula or milk. Okay. So diagnosed by trying to reduce their fluid intake, but the polyuria continues. Okay, so they're still having excessive urinary output even with reducing their fluid intake. Okay. So this is usually an issue with the posterior portion of the pituitary gland. So you're going to have hyposecretion or less secretion of antidiuretic hormone. So these kids are going to be diuresing a lot, okay? Because they're not making enough antidiuretic hormone. Does that make sense? It's kind of confusing. There can be a family history of this, or it can be just unknown idiopathic, okay? For primary cause. Secondary cause, so this can happen if this kiddo has had a recent trauma, or if they have a tumor, or a central nervous system infection, or if they have an aneurysm, okay? So these kids are not making enough antidiuretic hormone, so they're urinating all of the time. That's diabetes insipidus. Managing diabetes insipidus. So obviously tell these kids and these parents the difference between diabetes mellitus and diabetes insipidus. They do not have diabetes. They do not need insulin, okay? They need hormone replacement. So you're using DDAVP or vasopressin. There's IV form of DDAVP, there's nasal forms, there's sub-Q, there's IM, and they're going to be on these treatments for life. Okay. But not needing insulin. Okay. Syndrome of inappropriate ADH. So SIADH. This is over secretion of ADH. So increased antidiuretic hormone. So these kids are holding on to fluid. They are not diuresing like the kids who have diabetes insipidus. Okay, so they're going to have low tone. The kidneys can no longer absorb the water. So, it's going to they're starting to third space. So the fluid is starting to go outside of the cell. Okay. These symptoms are relieved when antidiuretic hormone is decreased, so they can urinate appropriately again. You'll see personality changes, irritability, vomiting, nausea, anorexia, and that's because they're holding on to that fluid. Okay, and their pressure in their brain is increasing because they're holding on to so much fluid. Management of SIADH, so making sure you're doing accurate eyes and nose with any of these ADH involved diagnoses, okay? So whether it's diabetes insipidus, you need to be doing accurate eyes and nose, or SIADH. So daily weights, you're gonna look for fluid overload, These kids will be water restricted. A lot of times they're on a low sodium diet. Because of that, you're concerned about them becoming too dilute. So you want them on seizure precautions. Vasopressin antagonists are the drugs that bind to the vasopressin receptors, and then that blocks ADH. Okay, vasopressin, ADH is the same thing. Okay, antidiuretic hormone, ADH, vasopressin. Those are all the same things. So they're going to be given antagonist to vasopressin. Okay. Okay. Disorders of the thyroid. So the thyroid regulates a lot of your basal metabolic rate. So there's two types of hormones that are secreted. So T4 and T3. Okay. That's the two different thyroid hormones. And then it also secretes calcitonin. Okay. Patients can either have hypothyroidism or hyperthyroidism. And then there may also be a disturbance in the secretion of thyroid stimulating hormone, or TSH. Hypothyroidism, so there is a congenital form of hypothyroidism, which that is typically because the thyroid gland did not fully develop, okay? So this kiddo is a kiddo that the congenital hypothyroidism wasn't found for quite a period of time, so they have the, have physical defects from the fact that their thyroid gland was not it was not found that their thyroid gland was not producing enough TSH, okay, or acquired. So this can come from when they're removing a portion of the thyroid due to cancer because we're having too high of thyroid hormone. Thyroid toxicosis is what that is called. So that would be an acquired form of hypothyroidism, or also after radiation from Hodgkin's lymphoma or another malignancy. Okay. Rarely happens in the United States from a dietary insufficiency. However, if you have a patient that's from another country and don't have access to the foods that we do, then this may also be a concern. So presentation of hypothyroidism, hair loss, mental decline, constipation, increased sleepiness. They're going to more puffy or swelling around their eyes. Okay, dry skin. You're going to see a lot of skin changes. So oral thyroid hormone replacement with levothyroxine is going to be your most common management type. Okay, this is important for normal brain development in the infant. So if you and it's usually on newborn metabolic screening. If it's a congenital hypothyroidism, it will come back on that. However, sometimes it is missed. So just as soon as you have concern of hypothyroidism, these kids need to be given supplementation or replacement therapy with levothyroxine. Usually 4 to 8 weeks is then you kind of reevaluate every 4 to 8 weeks when these kids are taking thyroid hormone, and you're monitoring for signs of hyperthyroidism. If they start to have signs of hyperthyroidism, then they need their levothyroxine dose adjusted. Okay, making sure that they're compliant with their medications. They're taking the levothyroxine 30 minutes before they have anything in their stomach is really important, and you're going to closely monitor their height and weight. Okay. A goiter. So this is hypertrophy of the thyroid gland. So this can happen from mom taking antithyroid drugs during pregnancy. So taking certain medications that cause issues with the thyroid in the infant, or also an acquired reason. So they have malignancy or neoplasm, there's an inflammatory disease, or like I said, the dietary deficiency, or an increase in the pituitary thyrotropic hormone. So treatment of a goiter is having removal. Okay. And they can become more prominent or more noticeable during periods where these kids are growing a lot. Thyroid hormone replacement is necessary after they remove the goiter, because these kids will have hypothyroidism. Okay. And it's really important, if as soon as you identify a goiter, that needs to be removed. Okay. Lymphocytic thyroidosis, or Hashimoto's disease, or autoimmune thyroiditis. So this is the most common cause of thyroid disease in children and teenagers. You'll also see this in adulthood, but it's most common in children and teenagers for diagnosis. The biggest cause of hypothyroidism in children. And then it's frequently after age 6 that it's diagnosed and noticed. And then it usually peaks during adolescence. So you'll notice in a large thyroid gland, it's usually the same on both sides. So it's usually symmetric. It's going to be firm, non-tender, freely movable. Okay. There may be tracheal compression involved because of the sense of fullness. So these kids might start refusing to eat, or they might start having problems with speaking, or having a hoarse voice. Hyperthyroid symptoms may be also possible depending on the involvement. Okay. Thyroid function tests are usually normal, so a TSH is a lot of times normal. Okay. But a TSH may also be slightly elevated. But when you check their antibodies, their anti-thyroid antibodies are present. So that's kind of how you look at diagnosing lymphocytic thyroiditis or Hashimoto's disease, is they'll have those anti-thyroid antibodies. And if they do not have Hashimoto's thyroiditis or Hashimoto's disease, then they will not have those anti-thyroid antibodies be present. Okay. They may have a goiter. It might kind of come and go. It might go away on its own within a year or two if they have lymphocytic thyroiditis. They will need the oral thyroid hormone, just like somebody with hypothyroidism. And this a lot of times helps with their goiter that these kids typically have. You do not do surgery for this disorder because of the autoimmune aspect of it. Okay. So no surgery if they have autoimmune thyroiditis. Okay, hyperthyroidism, or Graves' disease. You can see this little girlie has those protruding eyes, which is a common finding, exophthalmos. And then you can also see she clearly has an enlarged thyroid. You can see right there in her neck, that little nodule. So this girlie obviously has Graves' disease or hyperthyroidism. Okay, it's the most common cause of hyperthyroidism in childhood, and it's an autoimmune response to the TSH receptors. Okay, usually between 12 and 14 is when it peaks, but it might also be present from birth. This is usually family history. Management of Graves' disease is sort of controversial. The goal is to reduce the amount of hormones that are secreted. So you'll have kids use PTU or polythyrazole or methimazole. But the concern with these drugs, so the anti-thyroid drugs, would be leukopenia, so low white count, fever, and sore throat. So they can kind of become more at risk for infections when they're on these drugs. So that's why it's controversial to use these medications. So what's more likely that will happen is they'll do either an ablation with radioactive iodine, or they will remove almost all of the thyroid. So if they remove almost all of the thyroid or all of the thyroid, these kids will have to have thyroid hormone. So they'll have to be on levothyroxine. Thyroid toxicosis. So this is a thyroid storm or a thyroid crisis. So this is when we become, a lot of times you'll see these kids, they're going to become really tachycardic. Their blood pressure is going to decrease. It's really life-threatening. So important that these kids get prompt treatment. A lot of times it can happen after surgery or after they have an infection, or after they've stopped their antithyroid therapy. So after they've stopped their PTU, okay, or their Tapazole or propranolol, okay. And then treatment is giving them the antithyroid drugs. Kids with hyperthyroidism, they're going to need rest periods, and then to work with their family to cope, because after they've had thyroid toxicosis, a lot of times their body's just really amped up still. So trying to decrease their stimuli is helpful. These kids are going to need higher calorie count because of the increased metabolic rate that they have when they have hyperthyroidism. Okay. And then talk about the medication side effects of the PTU, which is, like we said, leukopenia and kind of increased risk for infections. Okay, disorders of the parathyroid. So parathyroid glands secrete parathyroid hormone. So this functions to maintain calcium levels. Okay, it increases the release of calcium and phosphate from the bones, demineralizing. So increasing the absorption of calcium and excreting phosphate. So phosphate and calcium, whatever is happening, it's going to be the opposite. So if calcium is high, then phosphate is going to be low. Okay. And then PTU also, or excuse me, PTH, parathyroid hormone, also increases calcium absorption in the GI tract. Okay, usually from an autoimmune condition or an infection. Can also happen after having their thyroid removed. Okay, and then it can happen during the neonatal period. So when babies are young, if mom has hyperparathyroidism or diabetes mellitus, or they're eating a formula that has a high phosphate to calcium ratio. Okay. Manifestations of hypoparathyroidism, so low parathyroid hormone, is going to be similar to low thyroid hormone. So dry, flaky skin, brittle nails, headaches, seizures, memory loss, depression. Okay. And you're going to be looking at the plasma for the parathyroid hormone instead of whole blood. So, and it will have a low plasma parathyroid hormone. Okay. You'll also notice transverse grooves, so in the nails, so like a white line across their nails. A lot of times you'll notice that. And then they may have paresthesia, so numbness or tingling, or laryngeal stridor or spasms, or tetany. And that's because of the low calcium. Okay, management of hypoparathyroidism is giving them vitamin D therapy. Okay, we're going to be looking closely at the calcium and phosphate levels. Okay, you need to immediately correct tetany, which is by giving them vitamin D therapy or other supplementation, monitoring blood pressures, and serum vitamin D levels. So looking at the whole blood vitamin D levels. Seizure disorders, seizure precautions are necessary in these kids too with hypoparathyroidism. And then watching for laryngospasm. So maintaining their airway as well. Hyperparathyroidism. So this is usually adenoma, so a tumor of the gland, of the parathyroid gland, okay? And then secondary causes can be chronic renal disease, so they're in renal failure. They have maybe a congenital abnormality of the urinary tract. Common factor is high calcium in the blood. This is pretty rare in kiddos. I've never seen a kiddo with hyperparathyroidism, but it's potentially a potential. So you'll see increased calcium and decreased phosphorus in a kiddo who has hyperparathyroidism. Whereas with hypoparathyroidism, you see decreased calcium and increased phosphorus. Okay. Surgical removal of the tumor or treating the underlying cause. Okay. Acute adrenal cortical insufficiency. So adrenal crisis, this is medical emergency, it's life-threatening. So they need to be seen right away in the ER. It's caused because of a lack of cortisol. So you're going to see abdominal pain, vomiting, loss of consciousness, dizziness, weakness, sweating. Can happen from hemorrhaging from trauma into that gland, infections, stopping exogenous cortisone, so stopping the steroids too quickly. You can see this happen. This is why if you order a steroid, or if people are given a steroid for longer than just a few days, like 10 days at max, they need to be tapered off of their prednisone because otherwise they can go into adrenal crisis. Okay, it's pretty rare in children, but obviously looking at replacing their cortisol, replacing any bodily fluids, and then doing tapers with Solucortev. Cushing syndrome. This is something that happens if you are having excessive circulation of cortisol. Okay, so if these kids are routinely taking steroid therapy for a prolonged or excessive time, then you'll start to see some of these Cushing symptoms happening. So the buffalo hump, the moon face, so the really full face, weight gain, slower healing cuts, irregular menstrual cycles in women, and erectile dysfunction in men. You'll also see them start to have abdominal striae or excessive hairiness, so hirsutism can start to happen as well. Okay, so there's a lot of potential effects if you're on prolonged steroid use. It is reversible once you stop the steroid use, usually, okay? And like I said, this happens with an abrupt stop of steroids. And then you're going to see the acute adrenal insufficiency. Here is, once again, another picture of your cushingoid appearance. So excessive hair growth, striae, moon face, red facial cheeks, weight gain, poor wound healing, easier bruising. They're going to have more thin extremities than the rest of their body. Management, so of Cushing's disease, this depends on the cause of the Cushing's disease. So you may need surgical intervention if there's some sort of tumor on the adrenal glands that's causing the Cushing's. They may also need replacement of growth hormone, ADH, so antidiuretic hormone, thyroid hormones, gonadotropins, and steroids, depending on the cause of the Cushing's disease. Steroid administering steroids early in the morning or an every other day type of schedule. Okay, and then these kids, if they have Cushing's disease, they need to be monitored more closely for complications after surgery. Okay, adrenal function. So adrenal cortex, that secretes the Glucocorticoids, so cortisol and cortisone, mineral corticoids, so aldosterone, and then the sex character, it's steroids or sex hormones, so androgens, estrogens, and progestins. Alterations in any of these produce significant dysfunction. So adrenal medullary system secretes catecholamines, so that secretes epinephrine and norepinephrine. And then if you have a catecholamine secreting tumor, so a tumor that's secreting epinephrine and norepinephrine, then this is the typical cause for adrenal medullary hyperfunction. Okay. So congenital adrenal hyperplasia, this is pretty rare. So this is an overproduction of the adrenal androgens or testosterone. So this can happen in a female fetus. Females will have male sex hormones or more prominent male sex hormones. Okay, so usually there's some ambiguous genitalia, so kind of male, female appearing genitalia. Okay, salt wasting is frequently a crisis for these kids because of their dysfunction of their adrenal glands. Okay, it's diagnosed based on congenital abnormalities. So these babies are born with abnormalities such as ambiguous genitalia and also abnormal findings on their newborn metabolic screening. Therapy of congenital adrenal hyperplasia, this is going to be giving them glucocorticoids and then diagnosing and assigning the child their sex based on their genotype. So looking at their actual genotype of their sex to be able to determine what their sex is going to be. So sometimes at birth, depending on how significant the congenital hyperplasia is, these kids need to have reconstructive surgery of their genitals.
Okay. I have a question, Professor.
Yeah.
Can a parent choose that?
A parent can choose that, but
if it goes off the genotype, can they say like?
Can they choose the opposite?
Yeah.
I think that would be an ethical dilemma, probably, that would have to be reviewed by a board. I mean, I don't know. It would probably depend on the place that the child was having the reconstructive surgery done, and where the child was born. But I would bet that it would have an ethical review board if the parent was trying to choose a separate sex from the genotype. So I guess I can't tell you for sure that would be an option for parents, but I bet that there would be an ethical review board on that scenario. Okay. And these kids will not be able to have children themselves. Okay. And you can see, okay, here's the enlarged clitoris and then the fused labia majora. So this was somebody who was, female likely, but it just didn't fully develop. Phenochromatocytoma. This is an adrenal tumor that secretes epinephrine and dopamine, so catecholamines. These tumors are usually bilateral, so they're usually on both adrenal glands. Okay, and too much adrenaline is so epinephrine is getting produced. Okay, surgical removal of the tumors. And a lot of times these tumors are benign too. They're not always, or most of the time they're not malignant in pheochromocytoma. Okay, removing the tumors, and then a lot of times if the tumor is really invasive to the adrenal gland, they have to remove the entire adrenal gland, and then these kids will be on glucocorticoid and mineral corticoid therapy for their life. What's important is monitoring for behavioral changes and high blood pressure because of the removal of the adrenal glands. Disorder of pancreatic hormone secretion. So diabetes mellitus is a disorder of pancreatic hormone secretion, okay, because the insulin hormone is either partially deficient or totally deficient. So if it's type 1, that's totally deficient insulin, okay? And if it's partially deficient, then that's usually type 2. This is the most common endocrine disorder of childhood, usually peaks between ages 10 to 15. And then there's increased risk for Hispanic and African American children. Hypo or low blood sugar, hypoglycemia, you're going to see similar signs to what you see in adults. So jittery, sweating, fatigue, eventually stupor, dizzy. Okay, type 1, so this is the destruction of the beta cells in the pancreas that leads to total insulin deficiency. Okay, usually diagnosed in childhood or adolescence, but can happen at any age. Most children are have type 1 diabetes. However, that is becoming actually less of the most common type now that so many children are obese. And then type 1 diabetes is more prominent in Caucasian. Type 2 diabetes, like I said, is becoming more popular because of obesity and insulin resistance. So their insulin not working like it should. Most commonly diagnosed after age 45. Kids who are of Native American descent, Hispanic, or African American, they're more at risk specifically for type 2. These kids may need insulin injections, but they may also just get, like metformin or some oral medications to help with their insulin resistance. Ketoacidosis is defined by the presence of ketonuria, so ketones in the urine, okay, and hyperglycemia, so high glucose. So these kids will be spilling ketones in their urine, and they'll also be spilling glucose in their urine. So the body cannot break down the glucose in this situation when they're in ketoacidosis. So instead, there's ketones that are broken down and then eliminated via the urine. You'll also notice that acetone breath in these kids who are in ketoacidosis. Okay. This is a medical emergency, just like it is with an adult. It's also a medical emergency in pediatrics. So you will notice progressive deterioration because these kids will become dehydrated and there'll be electrolyte imbalances, and then eventually acidosis, progressing to coma and maybe death. Okay, these kids will be in the ICU, usually with an insulin drip. Okay. Looking for risk factors of diabetic ketoacidosis. Like I said, you'll have glucose in your urine and also ketones in your urine. So there are 4 different ways to confirm diabetes mellitus. You can have a 8-hour fasting glucose one time of 126 milligrams per deciliter. That will get you a diabetes diagnosis. A random blood glucose of 200 or more, that will get you a diagnosis of diabetes. Oral glucose tolerance test of 200 milligrams per deciliter or more in a 2-hour sample, or a hemoglobin A1C of 6.5 or more. So those 4 tests will confirm diabetes mellitus. Management, so sometimes these kids will have insulin. There's different dosages based on the severity of their need. Okay. If they are in the hospital with DKA, they will be on insulin. A lot of times they'll also be discharged on insulin until they're more stable. Okay. You're going to be frequently monitoring their blood glucose, their glycated hemoglobin, or A1C. That's the other term for glycated hemoglobin, and their urine to be checking for ketones or glucose. These kids with diabetes, you're going to be monitoring them with other care professionals. So you're going to be working with a lot of times dietary, diabetic educator, a lot of times the endocrinologist, the hospitalist of these kids, or the intensivist of these kids who are admitted. You're going to be closely monitoring their urine, testing for ketones and glucose. You're going to be looking for signs of hyperglycemia and signs of hypoglycemia. Okay. These kids need to be involved in the management of their diabetes. So, you know, teaching them about their insulin, teaching them about their glucose monitoring. A lot of times now they have continuous glucose monitoring. So, teaching them how to manage that. They'll also a lot of times have insulin pumps now that they can give themselves insulin through the insulin pump instead of having to do a shot every time. So working with these parents and supporting these parents and kiddos in their managing their diabetes. Okay, a nasal spray of desmopressin or DDAVP is used to treat which of the following conditions? Select all that apply. Did you say B?
B as in boy,
Yeah.
D as in dog.
Yeah. Anyone else have anything? That's
Is it
correct.
A or is that
Nope.
it?
Nope. B. So
What about
days
C?
insipidus.
E.
And D, SIADH. And adrenal cortical insufficiency. Sometimes DDAVP is utilized.
So B, C, and D.
Yes. B, C, and D. Good job. All right, we have 5 minutes left, so we can see if, I guess, do you guys have any questions? You see my computer has decided to not show me. Do you have any questions? Otherwise, we'll get into the Kahoots.
Does our math show up on exemplify score?
You know, I'm not sure. Like I said, I've never had that happen before, so
Or is that something that you guys go through to check?
well, we always go through and check that to make sure that they're all correct. But like I said, I'm not sure that if that's calculated in or not. And I'm not even sure that whatever you guys saw was accurate. Like I said, with the issues that Exam Soft had today, I'm not even sure that what all you guys were displayed was correct. So I'm not sure why it did that. And I'm also not sure why the calculators weren't working for you. Did everyone's calculator not work then?
They didn't
No.
work.
Mine worked fine.
Mine worked fine.
Okay.
Mine worked as well.
Mine was fine as well.
Okay.
Three.
Some of you guys. Okay. Okay. Yeah, all like I said, I plan on emailing Dr. Brown and all of the other PEDS instructors to see if they had issues with all of that as well. And then, like I said, we'll talk about make sure that we have that all accounted for. Okay. Any other questions? Okay. Make sure you guys have emailed me You should have already emailed me your topics for your projects. If you have not done that yet, please email me. Hopefully you haven't started working on them, and then when I email you back, if someone else has already had that topic and emailed me about it, then you'll have to choose a different topic and restart your project. So make sure you guys are looking into that and
Am I
shooting
using-
me an email.
Are we using your
What was
email
that?
or are we messaging you? Or Canvas?
Email or Canvas. They both come to my email, so whichever
Okay.
works better for you guys. Just make sure you're telling me your topic, and I'll message you back if you have to pick something else, because another student has picked it already. Okay, so make sure if you haven't done that, you're doing that, because it's due next week, and it's a big project. Okay. Week 9, so is Labor Day, is our class. We're supposed to have a quiz that day. I'm trying to figure out with the other professors what all they're going to do with their students for that quiz. They're going to have you guys just join another class that works to take the quiz that week, or if you guys would prefer to just hop on and do your quiz at our usual class time and then be done and not have an actual official class. So I don't know if you have a preference for either of those things.
Question, where can I find the topics at?
The topics. So under
There's
the assignment, there should be a list of, and I mean, essentially any pediatric diagnoses you can choose. So you can choose like asthma, you could choose ADHD, you could choose hypothyroidism, you could choose Graves' disease, you could choose whatever. It just has to be a pediatric specific diagnosis. Did you find it under the assignment?
No, I don't see it actually.
Okay.
I see it say the week 8 clinical pediatric assessment. You must pick a topic approved by you, but like I don't see like where the list is for me to choose from.
Okay, let me look closer here.
Are you in your modules looking at it?
Try to go to my just.
Yeah, because on my side, it's under the module for week 8.
For
I
week
should just
8.
emailed you.
Okay. I'm sorry, I was looking at the wrong week. Okay.
Nope, you're okay. You're okay. I want to make sure you guys all can see some of the things you can choose from. But like I said, you can use any pediatric specific diagnoses. So if there's something that's not on that list that you want to use, just email me and I'll say, yep, that's fine. Or no, I think you need, something that is going to be easier for you to get information on. Okay. So make sure you guys are all sending me that. Any other questions? Otherwise, you guys can have a good day, okay? Let me know if you need anything from me. Bye.
Oh,
Yeah,
Professor, in a breakout room real quick before you go. I just had a quick.
If you just stay on, everyone else will hop off. So, yep, just stay on.